The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Welcome to our Delegation Strategy Coaching Clinic. Delegation is a skill that you definitely have to learn as a nurse in the United States. And it is a strategy that is going to be tested, a skill that's going to be tested on your NCLEX exam. And so there are specific steps and things to consider and information to know when you're evaluating a delegation question to determine the correct answers. And so that's what we're going to be looking at tonight, what it is that we can delegate, to whom we can delegate, and then some practice with actually applying the delegation strategy. So let's talk first and foremost about why we would want to delegate. And the primary reason there is that there is more nursing to do than there are nurses to do it. And by nurses in this statement, particularly, we mean registered nurses. And so many of those registered nurses are stretched to the limit in the current chaotic healthcare environment. And as we all know, things like COVID don't make that any easier. So having just finished that pandemic, we never know which one's going to come next and what that's going to be like. We have to be prepared to be able to manage the care of our patients well and use all of the available resources we have, including assistive personnel who can help to lighten the load and accomplish the goal of the patient care that we need to accomplish. So more than ever, our nurses need to work effectively with unlicensed assistive personnel as well as licensed practical and vocational nurses who are licensed nurses but at a lower level than the registered nurse. And we have to have the ability to delegate, to assign, and to supervise those personnel, and those are critical competencies for the registered nurse to possess. So in 2005, both the American Nurses Association and the National Council of State Boards of Nursing adopted papers on delegation, and they both presented the same message, that delegation is an essential nursing skill. That joint statement was then updated in 2019, and those national guidelines for nursing delegation reflect an effort to standardize the nursing delegation process across based on research findings and evidence in the literature, and is applicable to all levels of nursing licensure, whether that's advanced practice nurses, registered nurses, or licensed practical and vocational nurses. So that joint statement says that although there is considerable variation in the language used to talk about delegation, both the ANA and the NCSBN defined a delegation as the process for a nurse to direct another person to perform a nursing tasks and activities. The NCSBN describes this as the nurse transferring authority, while the ANA calls this a transfer of responsibility. But both mean that a registered nurse can direct another individual to do something that that person would not normally be allowed to do, except that the registered nurse is supervising them. And both papers did stress that the registered nurse retains accountability for the delegation that has been made. The joint statement continued to say that both the ANA and the NCSBN acknowledge that delegation is a skill that has to be taught and practiced for nurses to be proficient in using it in the delivery of nursing care. And U.S. trained RNs are educated and mentored on how to delegate and supervise others, as nursing schools provide didactic content as well as simulated and realistic practice environments. But also remember that the NCLEX examination test plan includes competencies related to delegation. So as international nurses, it's important that you understand how delegation works and what your role in that would be. So what do you need to know? Well, first and foremost, you should know what activities can legally be delegated to an LPN or an unlicensed assistant under your state's regulations. And many tasks cannot be legally delegated to assistants because they exceed the scope of practice for these job roles. So if you feel uncomfortable delegating now, just be aware that you can increase your confidence and build your critical thinking skills. Realize that you don't have the capacity to do everything on your own, and successful delegation can improve your efficiency in achieving your goals for your patients. So what else? Well, never underestimate the role delegation plays in safety and quality outcomes. When you feel rushed or overworked, Ask yourself which tasks you can delegate to an assistant to keep your patient safe and comfortable. While delegating can unburden you from tasks and that others can complete, remember, though, ultimately you are accountable for the care outcomes. And so when you delegate to a specific individual, you must be sure that person has the knowledge and skill needed to complete the task safely and effectively. In general, you will be delegating tasks that do not require professional nursing assessments and judgments while they are being implemented. Always consider the degree of supervision that will be required when you delegate a task to a nursing assistant. Do you have to check on this assistant caregiver periodically or only when the task is completed? Treat nursing assistants with respect and remember that collaborative care contributes to better outcomes. Nurses should never be combative or dismissive about the work performed by assistive staff. Develop healthy interpersonal relationships with your assistive staff and remember that your communication style influences those relationships and the spirit of teamwork on your unit. Lastly, recognize the contributions of support staff and thank them for a job well done. Really, guys, it is important for you to understand that your LPNs and your unlicensed CNAs, they can really make or break you, and they can give you a really great support on your shift, or they can make your shift really not fun. So it's important that you recognize the contributions they make and that you treat them as the professionals they are. Because regardless of the level that a person works at, in their role, they are a professional, and they needed to be treated with that same respect that you would expect a doctor to treat you with, or a nurse practitioner to treat you with as the bedside nurse. Just because your level of training is different does not mean that a person should be disrespected in their role. So you want to make sure you're passing that along to your colleagues that assist you in your providing of bedside care. All right, so what all does that mean? The assignment of care to others, including nursing assistants, licensed practical nurses, and even other registered nurses in the event that you're charged, is perhaps one of the most important daily decisions that nurses make. Proper and appropriate assignments facilitate quality care, and improper and inappropriate assignments can lead to poor quality of care, disappointing outcomes, and the jeopardization of client safety, and even legal consequences. So you must learn the art of delegation to be successful here in the U.S. So now we have to choose, what are we going to delegate? Well, first and foremost, always remember your client is the center of care, so everything should proceed outward from that. The needs of the client must be competently met with the knowledge, skills, and ability of the staff available to meet those needs. Appropriate decisions to the successful assignment of care are based on the needs of the patient, the skill of the staff, the facility's policy and procedures, and the state's legal scopes of practice for nurses, nursing assistants, and other members of the nursing team. So there are 5 steps in delegation, or 5 rights that you might want to remember. And these are going to help you when you're making your decisions about what and to whom to delegate. First is the right person. Next is the right task. Next is the right circumstances. Then the right directions and communication, and the right supervision and evaluation. So in other words, the right person must be assigned the right tasks under the right conditions. And the nurse who assigns the task supervises the person and determines whether or not the job was done correctly, appropriately, safely, and competently. So that leads us to who can do what. And the difficult part in some respects is that not every state has the exact same scope of practice definitions or the exact same allowances for delegation. So whatever state you end up working in, it's important that you review your Nurse Practice Act so that you really do understand what you're allowed to delegate and to whom. However, there is generally a broad level of overlap from state to state, and that's what you're tested on the NCLEX. So states throughout the nation do have legally scopes of practice for registered nurses, licensed practical nurses, and advanced practice nurses. And they also have legal guidelines related to what an unlicensed assistive staff member such as a student nurse technician, a patient care aide, a patient care technician, or nursing assistant can and cannot legally perform, regardless of whether or not the healthcare provider or the delegating nurse believes that they are competent to do it. And although these legal and legislative scopes of practice vary from state to state, they share a lot of commonalities and similarities. So specifically, the scope of practice for an RN generally includes the legal ability to provide or perform all phases of the nursing process, including assessment, nursing diagnosis, planning, implementation, and evaluation. While the scope of practice for the licensed practical or vocational nurse generally includes the legal ability to perform data collection, to plan, implement, and evaluate care under the direct supervision and guidance of the registered nurse. So then come your unlicensed staff. These are allowed to assist the client with their activities of daily living, such as ambulation, dressing, grooming, bathing, and hygiene. They can measure and record fluid intake and output, and by intake we mean only oral intake, not IV or enteral intake. They can measure and record vital signs and height and weight. They can provide non-pharmacological comfort and pain relief interventions like positioning and cold packs and heat packs. They can establish and maintain an environment conducive to comfort, providing them with soothing and therapeutic back rubs or other types of positioning that can help. They are allowed to observe and report changes in the current status of the patient and their reactions to care. And they can transport clients and specimens and run other errands such as stocking of supplies. They can assist with transfers from bed to chair and chair to bed, range of motion, feeding, ambulation, and other tasks such as making beds and assisting with bowel and bladder functions. Each one of these are things your UAPs can do, and if they're helping your clients with these things, this frees you up tremendously to do the things that only RNs can do. So, rules, things to consider. First and foremost, scope of practice. What is this person allowed to do at this level? And remember, especially as far as your NCLEX goes and as far as what a person is legally allowed to do, an LPN who has 1 year of experience, or 1 day of experience for that matter, is not allowed to do any less than an LPN who has 10 years of experience. And that LPN with 10 years of experience is not allowed to do any more than the person or the LPN with 1 day or 1 year of experience. It's all the same because it's driven by scope of practice, not years of experience. The next thing you want to consider is that patient stable or unstable? Unstable patients do not get given away. They are kept by the RN. And then what is the likelihood of expected outcomes versus unexpected outcomes? This is kind of related to their stability or instability, but if you have a suspicion of an unexpected outcome, that's someone that requires more close monitoring, and therefore the RN would need to be the one doing that. And then reporting of data versus assessment and evaluation, which are formulating decision-making ideas about the plan of care, right? So things that you should remember that the RN only is allowed to do. The RN can do all initial teaching. The LPN and the CNA can reinforce teaching. The RN does the IV push medications. The RN does initial assessments like admissions or change of shift and change of condition assessments. And the RN can do anything that requires nursing judgment, such as titration of O2 on a vent patient or unstable patients like asthma patients or CHF exacerbation or DKA with those high blood sugars. RNs can perform any task that can also be performed by an LPN or a UAP. So it's kind of like your RN can do everything, but there are certain things that only the RN can do. And so the whole point of delegation is to free you up from the things that others can do so that you can do the things that only you can do. Your LPN or LVN, you should be assigning them stable clients and expected outcomes. You need to give them, they can give medications, anything except IV push, right? So they can give oral medications, rectal medications, injectable medications that are not IV push, and they can give IV medications through a peripheral access, such as a peripheral IV or a PICC line or a central line even, that are not push, right? They're being administered through some sort of a drip rate that doesn't require an active push. They can also do all of your wound care treatments, including clean and sterile and applying wound vacs. They can draw blood from a peripheral site through venipuncture or a newly placed peripheral IV. However, they cannot draw blood from a central access. Only the RN can do that. So if it's a subclavian or a PICC line or a port, the LPN cannot draw blood from those. They can manage and administer IV fluids and medications that are not IV push, as we said. They can place and remove NG tubes. They can manage enteral feedings by that NG tube, a G button, or a G tube. They can place and remove Foley and straight catheters. They can irrigate Foleys that have orders for that. And they can manage and irrigate enteral ostomies and manage urinary ostomies. They reinforce teaching, as we said, and they can perform any task that can be performed by the UAP or CNA. Speaking of which, the UAP or CNA is assigned standard and unchanging procedures. So think of ADL-associated tasks: the bathing, hygiene, feeding, measuring of oral intake, outputs, range of motion, ambulation, vital signs, pain scale, and finger stick glucoses. They do not give any medications, including ointments or creams, unless they are simply preventative. If it has a medication, so antibiotic ointments or other creams that are medicated, they cannot apply those. But they can apply things like A&D ointment or zinc oxide or lotion for skin relief, dry skin relief. They can collect and report vital signs, blood sugars, pain levels, any change. Mrs. Jones seems to be having some shortness of breath. They can say that, but they can't do anything about it, right? They can tell the LPN or the RN. And then the LPN or the RN will then address the need or the change, give a medication, whatever is needed at that point. And then they can also reinforce any teaching that has already been provided by the RN. All right, so what cannot be delegated? As we said, assessments, nursing diagnosis, establishing expected outcomes, evaluating care, and any other task or aspects of care that involve a sterile technique, critical thinking, professional judgment, and professional knowledge. So that's a lot of stuff to have to keep in mind now as you're thinking about what I can and cannot delegate. So again, just to give you this little nutshell view, the RN can formulate the plan of care and alter that plan of care. They do all initial education, assess, analyze, plan, intervene, evaluate, document, delegate, and the RN has to know the legal and personal scopes and consider workloads of all of the people involved in the assignment of care that day. The LPN follows the plan of care, reinforces education, intervenes, documents, does not do IV push medication, and does not do initial assessments or nursing diagnoses, but they do collaborate with the RN. And then your CNA, under the supervision of the RN, makes observations, collects data, reports information, is responsible for any tasks while the RN is accountable for that task. And then they cannot apply O2 as a new intervention, but they can get the canister, set up the tubing, do all of that. And once it's been applied, if a person is ongoing on the O2 and they take it off for whatever reason, the UAP is allowed to reapply it at that point. And then, as we've talked about before, the bathing, feeding, dressing, transferring vital signs, and then reminding patients of, calling for assistance and range of motion, they can do those things and document any data or tasks that they have collected. All right, so let's talk about some examples, right? Now that we've got all these generalities in our head, let's work with this king here. He needs to delegate. Let's do some delegation. So we have an RN who is planning care for the shift and will delegate to the LPN and the UAP. Which of the following patients is most appropriate to assign to the UAP? Would it be the client who is newly admitted with aspiration pneumonia, who needs an IV antibiotic administered via the peripheral IV? Or is it the client who is 1 day post-abdominal hysterectomy? Or the client who has just arrived from the PACU after a total knee replacement? Or the client newly diagnosed with type 2 diabetes mellitus? So I'm going to give you just a little bit of time here to think about this question, about 30 seconds, and then we will look at the thought process for answering this question. Okay, when we look at this question, we have to think about what's going on with these patients and what is it that's trying to be delegated. So in our first client, they've been newly admitted with aspiration pneumonia and they need an IV antibiotic administered via peripheral IV. Well, a UAP cannot do any medications and they can't do any IVs. So we know for sure number one is not correct. Number two is our client who is 1 day post-op or post-total abdominal hysterectomy. Well, a total abdominal hysterectomy, this person who's 1 day after their surgery probably still has a Foley catheter in place and probably needs assistance with ambulation. Therefore, we can think about giving this person to the UAP because the UAP can empty that Foley and they can assist with ambulation. And at this point, we don't see anything to preclude that. But let's check our other choices because remember, you always check all of your choices. All right, the client who has just arrived from the PACU after a total knee replacement. All right, so we have a little bit of a different scenario. Another post-op patient, but this one has just arrived, right, from the recovery unit. Therefore, they're going to need initial assessment by the registered nurse. So this is not someone that we would give to our UAP. And then the last client we have is newly diagnosed with type 2 diabetes, therefore new teaching that needs to be done. Therefore, again, the RN would have to take over this patient. Number one, we could actually give to our LPN, right? So we just know the UAP would not be able to do this one. So the only one that we actually can do is number two, right? So the client who is 1 day post-abdominal hysterectomy is somewhat stable the day after surgery, and the UAP can assist with the ambulation and emptying of the Foley catheter or measuring urinary output if they don't have a catheter. And so this would be the person who is most stable with unchanging procedures that the UAP can do. Okay? All right, question number two. A nurse is giving instructions to the nursing assistant regarding client care. Which of the following is the most appropriate statement for the nurse to make when instructing the UAP? Would it be to say, please check to see if Mr. Adams is experiencing pain relief? Or take a tympanic temperature for Mrs. Smith in room 3705 at 1700? Or get Mr. Barnes in room 3707 up today and let me know his progress. Thanks. Or would it be more appropriate for the nurse to say, show Mrs. Jones in room 3715 how to walk with her cane? So again, 30 seconds. Let's think about this question. Okay, So for this one, we see that our most specific instruction has to do with the tympanic temperature for Mrs. Smith in room 3705 at 1700. Our problems with the others include that, first and foremost, to see if Mr. Adams is experiencing pain relief, how are we going to measure that? How do we know if they're experiencing pain relief? What's our criteria for that? For Mr. Barnes, let me know his progress. That implies evaluation. How do I know whether he's progressed or not? You want to make sure that you're giving very clear instructions and that you're not asking a UAP to make an evaluation of a patient's status. And then the last one, show Mrs. Jones in room 3715 how to walk with her cane. Well, if I have to show her, that means she doesn't know. Therefore, it's new instruction. Again, the UAP is not to do new teaching. Therefore, the only one that we can do is have them take the temperature, and this specific instruction is given appropriately. It's what to do, for whom, where we need to do it, and when we need to do it, right? So that's why it's the best answer choice. Okay, question number 3. A nurse from the maternity is assigned to float to the med-surg unit. Which of the following clients is most appropriate to assign to the RN from this maternity unit? Would it be a 55-year-old client with tonic-clonic seizures? Would it be a 35-year-old client newly admitted with cellulitis? Would it be a 40-year-old client who has a knee replacement with a continuous passive motion device? Or a 30-year-old client with a mastectomy arriving from PACU? Again, let's have 30 seconds to think about these patients and what their care would entail to determine which of them would be the best to assign to a client, to an RN who's floated from the maternity unit. Okay, so when we think about this RN coming from the maternity unit, we need to consider what are the kinds of conditions that this person would typically deal with. Well, we know in maternity units, they deal with patients with placenta previa. They deal with abruptio placenta. They deal with gestational diabetes, with pregnancy-induced hypertension, with preeclampsia and eclampsia, with preterm labor, right? So we have to think about all of these things and what is a crossover of knowledge and skills that we can see with the clients that we're trying to assign to this person. Well, a client who's had a mastectomy is a fresh post-op client, but the care of a mastectomy is completely different than the care of a patient who's newly post-delivery or even new C-section, because mastectomy involves some very specific kinds of post-op interventions that are not common on the maternity unit. So we would probably not consider that client to be the right one. The 40-year-old client with a continuous knee replacement and the continuous passive motion device, that's not a device that's common on the maternity unit. So probably they're not going to be familiar with it, and it would be a real challenge for them to monitor that patient appropriately. The next one is our 35-year-old who's newly admitted with cellulitis. Well, cellulitis frequently is accompanied by some sort of infection. That's why they have the cellulitis, right? And we don't want nurses who are going to be handling newborns, because they're from the maternity unit, dealing with patients who are possibly infectious. Therefore, not a good match. However, this client with tonic-clonic seizures, well, in a maternity unit, a patient with eclampsia or preeclampsia is at risk for or may actually have seizures. So this is something this maternity nurse would probably be familiar with. Therefore, that's going to be our best choice for this particular nurse. Nurses working in maternity care for pregnant women who have hypertension and experience eclampsia. Cellulitis, though the bacteria is not indicated, we don't want nurses who handle newborns, handling infectious patients. And the fresh mastectomy, as we said, was going to have a different set of management needs as opposed to someone who is, for example, a C-section. So our correct answer here is choice number 1. Okay. Question number 4. The RN is doing staff assignments for the evening shift. Which client is most appropriate to assign to the licensed practical nurse? The client who was transferred out of the ICU 1 hour ago, a client requiring teaching on new medications prior to discharge, the client who is 2 days post-op from hysterectomy and will be discharged in the morning, or the client who is experiencing some bleeding problems and following surgery from the earlier in the morning. Which of these is going to be the best to give to the LPN? Again, take your 30 seconds to think about this question. Okay, in this case, we're looking at an LPN versus a CNA. So they have a higher level of skill, but even so, when we're comparing these clients, we have to think about what is it they can do and what are things that only the RN can do. So we have a client who's been transferred out of the ICU only 1 hour ago, initial assessment, right? So we're going to have to give that to our RN. The client requiring teaching on new medications prior to discharge. Again, new teaching, only the RN. And our client experiencing some bleeding problems following surgery, post-op complications, right? Not a stable situation, therefore, again, not someone we would want to delegate off to an LPN. However, the client who is super stable here, 2 days post-op and getting discharged in the morning, very stable patient. We can give this person to our LPN, and so that is the best assignment to make at that point. All right, question number 5. The registered nurse is working in a 30-bed long-term care facility on the night shift and is working with 2 licensed practical vocational nurses and 4 certified nursing assistants. Which primary care provider and nursing orders are most appropriately delegated to the LPN or LVN? Would it be inserting an indwelling urinary catheter, checking a client for liquid stools every 1 hour, assessing a newly admitted client, administering oral medications, or obtaining a stool specimen for culture, right? So in this case, it's actually a select all that apply. We failed to put that phrase there. So please know it's a select all that apply. So more than one answer choice could be correct. And take your 30 seconds to think about which of these would be correct to give to the LPN or LVN, knowing that you do have nursing assistants as well to assist you in the care. Okay, now when we look at this, we know our nursing assistant can do some very basic things, right? They can check our client for liquid stools every hour, and they can obtain a stool specimen. Those are 2 things we can give to our CNA. And we also know that assessing a newly admitted client is going to be strictly an RN task. So that leaves us with inserting an indwelling catheter and administering oral medications. And of the 5 options, those 2 are the 2 that we can give to our LPN, because we have the other 2 for the CNA. Those are within their scope of practice, and then the RN has to do that new admission assessment. And so that's our choices. Now, here is a common scenario. Near the end of her shift, an RN finds that the LPN and the nursing assistant have all their work completed and are sitting at the nursing station waiting for the next shift to arrive. The RN has been running all evening trying to juggle competing patient needs, such as administering blood and initiating IV antibiotics for patients assigned to the LPN and nursing assistant, answering a pharmacist questions about a patient's lab results, performing requests made by team members from other services, and trying to complete the care needed for her patients. The RN is struck by how overwhelmed she feels and questions the LPN and the nursing assistant about why they did not help her. The LPN and the nursing assistant respond that had they known or had the RN asked them to help, they would have, adding, "But we can't read your mind." The RN responded, "I didn't have time to ask. Couldn't you see I was busy?" Well, goodness, right? So what should this RN have done? Well, there's no doubt that she needed help. Her challenge was not really related to a lack of available personnel. Rather, it was because she performed work that others could have completed, and almost all RNs can benefit from strengthening their delegation skills to maximize the available resources. In that scenario, the RN is the person directing the work of the others, and she did not communicate with her LPN and nursing assistant about what needed to be done. In addition, the RN performed additional activities requested by other departments rather than redirecting some of them. This behavior is not uncommon. You will frequently run into that where people ask you to contact the healthcare provider and find out this or that. One of the best things you can learn to say is that's a conversation best had between you and the healthcare provider so that they can ask you the relevant questions they need in order to answer your question effectively. Don't pick up other people's work, okay? So when the physical therapist needs something from the HCP, it's their job to contact the HCP. When the dietitian needs something from the HCP, it's their job to contact the HCP. When the pharmacy has questions about lab results, it's their job to pull those pharmacy results up in the computer and contact that HCP if needed, right? It's not the RN's job to do the work of the other departments. A study of 170,000 healthcare workers found that RNs often perform inappropriate work or work that others could have done, thus contributing to the loss of the professional components of nursing. It's very important, guys, that you do learn your delegation allowances, the things that you can give to other people that will help you to get your work done, and also to not pick up work that is really best left to the other departments for them to address because it's within their scope of practice. All right, guys, that's it for this presentation. I hope you found this helpful. If you do have any questions, please don't hesitate to reach out to your instructor. We are always happy to help you with clarifying any delegation and navigating those kinds of questions so that you can be successful with them. All right, have a great rest of your day.